Well, thanks a lot, Glenn. No pressure there, then. Public health. I wondered when I was invited to give this talk why you would want to hear from a public health doctor, and I'm still rather wondering, but I've been making notes furiously over the last couple of days. But a man came to fit some carpets the other week, and he looked at it and said, Dr. Brambleby, are you a GP or are you a hospital doctor? A bit like one of the slides from our previous speaker. And I said, no, I'm in public health. And he said, oh, you mean herbs and crystals and all that. So that's, I will have to define public health fairly early on, I think, on that. And the other thing, Glenn, you mentioned culture this morning. So I've been trying to jot down a few notes about culture and how that's changed, prompted by the thought of herbs and all of that. Because if this was 2015 BC, the whole subject of procurement and needs assessment and providing for what people would require would be based around, well, here you are, you need take these herbs. That would be the answer. And really nothing much happened culturally, I think, in this country until the first Christian missionaries arrived, about AD 50. And they said, those herbs are pagan, you need to say these prayers. It should be faith-based. And indeed, the church dominated the culture, didn't it? And we have St. George's and St. Thomas's and St. Bart's and so forth. Until about 1850 AD, and then things pick up pace a little bit. We've got the Victorians, and it all became a bit more scientific. And they used magnetism and electricity and various potions. And they said, no, all of that faith-based stuff is out of date. You should be scientific, so buy these potions. But they didn't work very well. Then we got the NHS in 1948, and suddenly the potions became free at the point of delivery. And then things moved on a little bit further, and we got to about 1980 and the advent of evidence-based medicine, and people said, well, those potions don't work. What you should have are these evidence-based pills, and that was great. And then 1990, we got NICE, and NICE said, yeah, well, they work very well, but they're not cost-effective, so take these. And then we got austerity, and we said, well, I can't afford those, so take nothing. And the other day I was in the chemist's and I said, what have you got for insomnia? And he said, here, take these herbs. And I feel we've sort of culturally moved full circle, so that's great, isn't it? Quick answer to the 1 + 1 = 3 also occurred to me when you were talking digital this morning. If you do it in binary, 1 and a 1 is a 3, isn't it? So all you digital computer geeks will know immediately how to make 1 and 1 = 3. You just use binary, which is what computers speak, I'm told. Now, how do I advance this? Is this the next one? Great. Well, I better get on with my quick presentation. And can I just start with the definition of public health, which was redefined when public health was reviewed in 86 by Sir Donald Atchison. And it's both a science and an art, and I like that very much. And it's about prolonging life, promoting health, preventing disease through organised efforts of society. And everything you were talking about yesterday, and even more today, was about how do we organise ourselves as contributions to a very complex exercise in order to deliver those benefits, not just saving lives, but all these other things about prolonging useful life. And so, by that definition, you are all public health practitioners. So, welcome to my world. Well, this is my world and you're welcome to it. It's very much an integrative approach. That's the definition of public health. We do it together. It's about organising ourselves and for the benefits of society. And it's about an art as well as a science. I love this quote from Einstein that logic may take you from A to B, but imagination can take you anywhere. And if I want to leave anything with you today, it's not to have left you with a few facts that you might not have known before, because this is fairly fact and data light, this presentation. I just want to share a few insights into the nature of this problem and let you use your imaginations to come up with solutions. But this is a one point in the program where you can pause and just take a wider view. And I think that's probably the main thing I can offer to you as a public health practitioner, because we're used to taking a helicopter view and looking at impacts on populations rather than specific individuals, specific diseases, specific organisations. So my job, I think, in the next 20 minutes is just to open up some of the nature and scale of the problem and leave cleverer minds, more technical minds, more experienced minds to come up with specific solutions in your own situations. And the first rule of problem solving, of course, is to clarify the problem. And I've broken down what I was asked to talk about into 3 key areas. The first, and the one I want to talk about most, is what do we mean by integrated? And let's just unpack that and see how that applies in your situations. What do we mean by the benefits? And what is this, how do you get 1 plus 1 and make it 3? What do we mean by efficiency? So that's it, really. Right, integrated. Integrated first and foremost in terms of the patient journey. So it's really important that, absorbed as we may be in that patient's operation, or that patient's hospital admission, or the event as it was called, or the intervention as the economists would call it, that we remember that it's one step in an overall journey. And a typical journey, let's say this was lung cancer, for example, there's a lot that could be done in terms of preventing it. There are diseases, lung cancer is a good example, which are man-made diseases attributable to something in the lifestyle, in this case, smoking. So just pause for a moment and think, how does what we're doing in this particular stage of the journey integrate with the rest? And if I declare a bias, and this is more bias than strictly evidence-based, I think the NHS for rather too long has been concentrating on the treatment bit of this pathway, to the detriment, in terms of management time or even investment, of the other stages. They're all important. The rhetoric is increasingly moving towards prevention, and there's certainly a lot on end-of-life care, but I don't think we've got the overall balance right. Now, quick check, know my audience. How many, hands up, any of you who currently work principally in a CCG, i.e. as a Commissioner of Overall Healthcare? Just the one at the front, and Sam, you're speaking a minute. Okay, thank you. Good, because just for a minute, let me make you honorary members of a CCG. I'll give you a very quick allocative efficiency decision to make. A typical CCG will spend around £40 million a year on cancer. Let's focus on cancer. Next year, there's no new money, so next year your budget's going to be 40 million for cancer. Just within cancer, and do this at an instinctive level, okay? Would you like to spend more of that budget? There's no more money, but you can spend a greater proportion on prevention. Let's twin the next two. On diagnosis and treatment, or would you like to spend more of it on continuing care and end-of-life care? Okay, I'll give you 3 options. Are you ready? So, hands up, how many of you would like to spend a greater proportion of it next year on prevention? That's almost universal. That's very interesting. I am among friends. You are public health people. Fantastic. How many of you would like to spend more of it on diagnosis and treatment? There are some hands, and 1 or 2. And how many would like to spend more on continuing or end-of-life care? And a similar number, just 2 or 3 hands. That was interesting. Okay. Follow-up question. It's a fixed budget next year. By a vast majority, you wanted to spend more of it on prevention. So what are you going to spend less of it on? Okay. Where does the hit come from? Welcome to my world. The third question is, how would you explain that to the press? But I won't ask you to do that one. We haven't got time. So let's have another show of hands. You can't vote for prevention again unless you were the 3 or 4 people who voted for the other options. But I will ask, how many of you would take it from prevention? 1 hand going up, 2 hands going up. How many of you would take it from diagnosis and treatment? Slowly some hands are going up. It's hard to vote for a cut, isn't it? Okay, but at 5 or 6. And how many of you would take it from continuing care or end-of-life care? Again, the majority. How many of you failed to answer the 3rd time? Ah, you see. There you go. It's hard, isn't it? But that's the essence of it. And do you know, wouldn't it be easier to make that decision if you had some good data on, but exactly where would that investment go? How would I get it spent? What would be the return on that investment in its new destination, prevention? What would I have lost if I took it from treatment or end-of-life care? How can I weigh that up? That's economics. And that is something that's very much neglected, I believe, in our whole training of certainly doctors, public health doctors, managers, and people making this sort of assessment. This dawned on me fairly early on in my training, and I went off to learn some health economics from the excellent distance learning at Aberdeen, where they said economics is for people who find accountancy too exciting. So that shows how sad my life is. But I later got interested in program budgeting and asking the question, because I needed it for my own job as a public health practitioner in a commissioning organisation, how much does the NHS spend on things like cancers or heart disease? Each of the 20 chapters in the International Classification of Diseases, just, big issues. If you add together what goes on in the hospital and the GPs and the ambulance and so forth, very little data about that. So we went and started collecting it, and then we had a DH project, and we got all the PCTs, and currently CCGs send in an estimate every year on what they spend. But a colleague of mine who's health economist at the Department of Health, Andrew Jackson, and we went round and we interviewed each one of the then clinical czars. Do you remember? There's a heart disease czar and a renal czar and a mental health czar. We asked each of them, do you have a rough idea of how much is spent in your programme? They didn't. What would your advice be, czar, on how we should spread that investment at each step in the pathway? Because if you don't advise us, we're all going to make up our own minds. And to date, answer comes there, none. So that would be a really interesting one to follow through, wouldn't it? And if you'll forgive me one slight side joke, when Duncan Selby, before he went to run Public Health England, was the sort of strategy director for the NHS, and he pulled all the clinical czars together in one room to discuss some of these issues. And I was given an opportunity to speak to them, and I said, I've got a tune going around in my head, and it's from Paint Your Wagon. And it's the one that goes, I was born under a squandering Tsar. So we've got to integrate the patient journey, and don't lose sight of that. But also, and this was, I think others have mentioned this, it's very unusual for people only to have one disease. So say that was their pathway for lung cancer, and you're looking at a particular moment in that, you're trying to integrate their lung cancer journey. They got lung cancer because they were a smoker. And before they had lung cancer, they might well have had heart disease. And at the moment that you're intervening on their lung cancer journey, you're intervening at another stage in their heart disease journey, and I bet they'll have a bit of diabetes as well. And then you think more and more laterally, and you think, well, what about the dementias and the renal failures and all that? And what about when they lose their job and the impact that has on them? So the other way to look at integration is to integrate right across everything else that's going on in a patient's life. Walk for a time in their shoes and look about you and see what else is going on. So 2 forms of integration. There's more. People don't just exist in isolation. We are social animals. We are utterly interdependent with one another. Start with a person. They have their own particular genetic endowment. They have their gender. They have certain immutable things which make them who they are. Thank goodness, that makes us individuals. That makes us important. That's why we matter. And we can't change that. What we can change as individuals is how we then choose to adopt certain lifestyles, which is to eat, when we choose to start a sex life, whether we choose to get an education, whether we choose to smoke, exercise, all that sort of stuff. Personal choices, sovereign control and command, but can be influenced by external factors now, so that healthy lifestyle choices can be easier or difficult choices. Then, outside the individual and what they do, is their immediate social network. Most of us spend most of our time in a fairly close network of a family or a circle of friends or a workplace or a school. So you've got that immediate social support network, and then sitting around that is the wider socio-geopolitical environment and so forth. Now, that kind of layers of an onion are very commonly used in the prevention agenda. What are the causes and the determinants of ill health? What should we do about them? But it's more than just about causes. It's also where the cures can lie, where the answers lie. So one of the areas where we need to be integrated in our thinking and lateral in our thinking is, are there areas outside of the healthcare offer that we ought to be integrating into what we're doing within the NHS? Take our blinkers off for a minute and look a little bit wider. in terms of cures. And then the third element of my subtitle here is contributions, because, and this has come across very strongly, and it's good to hear it, that we must stop thinking of people as being purely the passive recipients of our benevolence. Why do we always start with a needs assessment? Why don't we start with an ability assessment? Why the first question is, what can you do? And how can we help you maximize what you can do, what do you want to do, rather than what can't you do, and start with a deficit and then try and fix it. When health and the concept of well-being is relatively new. It came out as part of the coalition government's health policy, and then we got health and well-being boards and that kind of thing. But they never defined well-being. And when I was working in Croydon, we tried to define well-being, and we came up with a combination of not just the absence of disease and infirmity, but some positive attributes as well. It was about being all you can be. And it was very much about making a contribution. Being integrated in society. And by that definition, if you weren't fully integrated and making your contribution, you weren't enjoying full well-being. So let's not forget that the patients with whom we're dealing can benefit by being allowed to make a contribution. They are very much part of the solution. They are not just part of the problem. Which brings us, therefore, to this sort of horizontal integration that we need to do laterally, not just between the different healthcare professions and making sure that primary care and secondary care can talk to each other electronically, working together, pooling their budgets, sharing opportunity costs, mixing it up between prevention and treatment and aftercare and all of that. But also we look across, so what's the contribution to and from social care to education, employment and all of that. You can get your pharmacology right, you can get your physiology right, get your psychology right, you get the sociology wrong, you can have a very handicapped patient. Not enjoying life to the full. Then the last slide on integration is simply the obvious point that integration will need an integrator. One of the candidates, not the only candidate, but I think a very strong candidate, should be the Health and Wellbeing Board. And they do a number of integrative things. It's a forum where different sovereign organisations get together and they talk together about what's our common understanding of the needs and the assets of our local community, what's our combined plan to do something about that, what are our joint priorities, what are we going to do by way of commissioning each in our own organisations. And incidentally, if you want to understand commissioning, just say it slowly, it's about co-missioning. Agree what the mission is, just do it together. It's as easy as that. All the rest is flannel and fluff. But also, I hope, and going back to Einstein and imagination and the art of public health, we should be taking risks and experimenting and trying new stuff. But critically, we should be evaluating it as well. The NHS keeps coming up with innovation funds and so forth. I think that's the wrong model, quite honestly. I think if the NHS has got £107 billion to spend, that's the NHS Innovation Fund. We should be constantly pushing the envelope, constantly trying to deploy all of that in a more creative way. What we need to set aside a little bit for is the evaluation budget, because there's so many good ideas haven't been properly evaluated. And evaluation simply means the degree to which you met your stated objectives. And the reason people aren't doing much evaluation is they're not stating their objectives clearly enough. That's a brilliant idea. Let's put a barcode on every blood product. But what for? Exactly what for? What are the benefits to the patient, the organisation, and so forth? How would we measure it and then evaluate it? So, alongside all this experimentation, I hope there'll be some evaluation. Incidentally, one of the joys of being a public health director is to get to sit on the risk management committee. And it's always nice to just gee them up and frighten them a bit. So the first question to our risk management committee was, okay, are we taking enough risks? Where are the risk takers? Are we pushing the envelope? It horrified people. No. This is the committee where we mitigate risks. We identify them so they don't happen. No, we should be pushing the envelope. It's always nice to turn things upside down. Talk about turning things upside down. I wish Sir David Nicholson had turned his famous challenge upside down. It shouldn't have been a challenge, come on NHS, how are you going to save 20 billion? It should be, come on NHS, what's the best way of spending 80 billion? Let's get on the front foot. Let's concentrate on what we've got, not whinge about what we haven't got. How are we going to spend what we've got to the best? Get everybody creative and thinking about it. By giving us a negative target, don't do that, people started squirreling money away, not engaging with one another, protecting their turf, and guess what? It didn't deliver. I digress. Sort of, because I'm coming on to benefits and efficiencies. So benefit, defined by the guru of quality in healthcare in the 1960s, Avidis Donabedian, benefit, a measurable improvement attributable to an earlier intervention. And he was thinking in terms of individuals, but I think in the context of today, we can talk about benefits not just to the patient, but benefits to the caring agencies and society. Measurable improvement. It's back to that discipline of being clear what you want and making sure you check that you've done it. But, of course, to this wider group. We talk a lot about outputs. We talk a lot about outcomes. I think, I'm trying to play on words here. I couldn't think of the right one, but outlook was the best I could come up with. So I put an exclamation mark by it to show it's not quite right. But I hope you get what I mean. I think one of the benefits of using our imagination and pushing the envelope is we get a whole new take on things. Why don't we put the patient in charge? Why can't they use their own smartphone? And just do something that changes the culture, changes the way we look at things, and certainly puts the patient at the centre. And then, of course, efficiency is about maximising your benefits from a given resource. I'm sure that integration with partners could improve efficiency simply because you're working from a bigger pool and you get that economy of scale. I only have one slide on efficiency, and this comes straight from the heart of a public health practitioner, because there's two sorts of efficiency. I think we've been talking about the first one mostly today, which is about technical efficiency. If you're given an objective like, let's make eye surgery and the use of the eye surgery theatre as efficient as possible, it's a technical efficiency issue. How do we get the biggest bang for that? How do we achieve that objective at least cost? How do we do it right? And if you've been able to do 1,000 cataract operations in a year and you can bump that up to 1,200, that would be technically much more efficient if you could do it with exactly the same resource of kit, people, and consumables. However, if you're a commissioner of visual health to the population, or bone health, heart health, whatever, you may not want, as your next efficiency saving, to have another 200 cataract operations. The return on your investment in terms of health gain may be relatively low because you're now dealing with people with less and less visual problem because you've already done the obvious ones in your first 1,000. And what you might want to do is some other area of eye care, like macular degeneration or refractive errors, or you might want to spend it on another program altogether, like learning disability or hearing or so forth. For a commissioner, or I guess for a hospital purchaser, it's sometimes a question of allocative efficiency, which is spreading your fixed budget between different programs in ways which will maximize the return on that investment. And a way to check that you're being allocatively efficient is to look and see, okay, we've set our boundaries, we've set our limits, we've had to put some parameters in. There's some people who will and won't get this offer. Is there anyone who's left outside the offer who has a greater ability to benefit than someone who's inside the offer? And you try and just calibrate at the edges. I'm not sure that thought process has been carefully enough delivered. And there are some very fashionable diseases at the moment. Cancer and heart disease are two examples where we're spending more and more on them, and we're not really looking at other people with other disease conditions, maybe renal failure, learning disability, hearing problems, who are being left out because we haven't been allocatively efficient. I'll leave that for discussion. I'm nearly done. Another one about innovation. What did Darwin actually say? It's not the strongest or the most intelligent who survive, it's the ones most adaptable to change. So don't be afraid to keep changing. That is the route to survival. And here's my summary. My suggestion is, and this is still scoping the problem, I'm not going to tell you what to do, you must do that for yourselves. But put yourselves in the patient's shoes, walk their journey and look around and see what else is going on. Just pause for a minute before you commit all your energy into one intense and exciting intervention and project. Do work with others, it's usually more effective and efficient. What you're trying to do is maximize all the benefits and the fund available. Experiment, please, but certainly evaluate, and for goodness sake, do what you do like at this conference, which is share the learning. And I'll leave you with that conclusion. So what are we trying to procure in a procurement environment? we're trying to procure integrated benefits through an integrated approach. Thank you.